Welcome, everyone, and welcome to this LHSN webinar on the Suspicion of Sepsis Insight Dashboard. My name is Mary Helen Pombo, and I'm the Global Health Policy Fellow at the Center for Health Policy within Imperial College London, and I lead the Leading Health Systems Network program. For those of you who may be less familiar with our network, the LHSN is an international network of healthcare providers that advances research and knowledge sharing to address health service challenges. We're based at Imperial College and work in partnership with the World Innovation Summit for Health. Today, our speaker joins us from Imperial College Health Partners, a partnership organization consisting of healthcare providers within the NHS, clinical commissioning groups, and leading universities across Northwest London. They are the designated academic health science network for the region, and their main objective is to develop and disseminate innovative healthcare interventions that address pressing issues to their member organizations. The Suspicion of Sepsis Insight Dashboard is precisely one example of their innovative solutions. Now, we at LHSN were interested in hosting this discussion for a couple of reasons. One being that as a member-requested webinar from our New Zealand member, the Waitemata District Health Board, we're really pleased to support learning about this tool in organizations globally. I've noticed that a few members of our audience listening to us now are in New Zealand, so a special thanks goes to you for joining us as we realize this is a late evening event for you. And yes, another reason for focusing on sepsis is because it is a leading cause of death for which we have no universally accepted definition. So this webinar seeks to respond to the WHO sepsis resolution adopted at the World Health Assembly in 2017. And at the same time, it seeks to complement our prior webinar series on antimicrobial stewardship, a set of policy and program interventions that we know are essential to curbing the incidence of sepsis. Now, before getting into more content, just a word about social media. We welcome you to join today's conversation online via LinkedIn and Twitter. Our handle and hashtag for this event are available on the presentation slide here. And we also invite you to send along your questions throughout the presentation in the chat box. With that, I'll briefly introduce our speaker. Kenny Ajayi is a Program Director of Patient Safety at Imperial College Health Partners, where he adopts and drives the adoption of innovation in patient safety across the health and social care systems in Northwest London. Prior, he worked in healthcare risk management, physiotherapy, and clinical ergonomics and human factors in the NHS and local authorities. Kenny completed a master's degree in ergonomics and human factors, as well as a master's in integrated governance in healthcare. Kenny, it's excellent to have you with us. The floor is all yours.
Thank you very much, Mary, and good morning, everyone, and or good afternoon or good evening, depending on what part of the world you're in. And it's a pleasure to join you this morning to discuss our work on the Suspicion of Sepsis Dashboard. What I'm hoping to do in the next 30-35 minutes thereabouts is to go through a few items on the agenda, if you like. First, I'd like to set the scene by looking at the measurement of sepsis outcomes globally and particularly in England, giving an overview of that, and then introducing you to the Suspicion of Sepsis Dashboard work, which I have led for the last 2.5 years thereabout. I'll give you some insight into what problems we are trying to solve, how we've made progress with that to date. I'd also then like to talk about the current impact that the dashboard is making and how that's being used. And very importantly, at the end of this, leave the floor open to ideas and collaboration. One of the things that we're looking to do is the dashboard itself is a product of collaboration in England. And we're also then now looking to, if you like, extend that collaboration further afield to the nations of other nations of the world where they might have similar issues. And that collaboration will involve a number of different formats. But for the moment, if I just get into the presentation and then perhaps we can discuss the finer details of the collaboration later on. Of course, I'll then end up with mentioning certain things that we have upcoming in terms of activities, both around the dashboard and perhaps at the general level. So if I just go ahead and itemize a number of questions that I'm hoping to address in the course of the discussion this morning. The first one really is, what problem does the Suspicion of Sepsis dashboard solve? What did we have in mind when we set out to introduce the dashboard and to design it? And secondly, what exactly is the dashboard? And for those who might not have previously seen it, I'm hoping to go live to the dashboard itself so you can see what it looks like in reality. I'm also looking to answer the question, who is the dashboard, or how is the dashboard being used at the moment? So how are clinicians in England and perhaps even other parts of the world using the dashboard right now? And very importantly, what are the opportunities for collaboration on the dashboard? So now, Mary mentioned previously about the organization I work for, so I wouldn't go into this. And by the way, excuse my manner. Thank you very much for that kind introduction, Mary. So I wouldn't go into the details of this, but suffice it to say that the organization brings about three different parties, if you like, or three different types of organizations to form a partnership to solve difficult problems in the health service. The first are universities, and the second type of organizations are private sector and industry type organizations, and thirdly, the NHS itself. So bringing those organizations together to solve complex problems within the healthcare ecosystem in England. So that's about us. Now, let me go on to talk about the first problem. What exactly were we trying to solve? What problem were we trying to solve when we introduced the Suspicion of Sepsis dashboard? And to put things into context, just to give a global picture, although we've tackled the problem from the England perspective, if you like, the reality is that the problem we're trying to solve is bigger than England, and it extends to a number of other nations in the globe. So, for example, these are all stats from the WHO website. And for example, we know that we don't quite know specifically the total number of patients who get sepsis on an annual basis globally. So we have difficulty in ascertaining the actual global epidemiological burden of sepsis. But it's estimated that approximately 30 million people have the disease annually worldwide. And again, that's an estimate. The fact that we're having to estimate itself tells us that we don't quite have a grasp on the data globally, which is partly one of the reasons why we've done the work we've done. And then we've also got an approximate 6 million people estimated globally to die from sepsis on an annual basis. Again, that's an approximation, or it's an estimation. So we know that people will develop sepsis either as a result of hospital admission or as a result of interaction with the healthcare service, or some of them will develop sepsis from an infection that developed in the community. So if you like, there are two main broad forms of entry, or two main sources of causative infection. It's either in the community or it's in healthcare setting. We know that the mortality is likely to be higher in middle and low income countries. And that's why I welcome a comment, or I believe a comment that's been made earlier around doing some work in low income and middle income countries, and helping those countries to perhaps get a better grasp on their sepsis treatment and sepsis pathways, and doing some kind of collaboration around that. So thank you for raising that point. I believe one of our participants made that point in our pre-webinar interactions. I guess the other point to make before moving on from this slide is that the evidence, reported evidence of data coding issues has been noticed in several countries. We know that for a fact that we know in England that that's a problem. We also know that in Australia, there have been publications that cited data issues in Australia. And of course, definitely there are data issues also in the United States. And these have all been published widely. So we know for a fact that the problem we're trying to solve is not just an England problem. Potentially, it could be a global problem, but at least it's a problem that affects multiple countries in the world. Now, just for the purpose of the discussion, if you like, let's just perhaps throw out a basic definition of sepsis out there. And it's the definition I'll be using is it's a severe life-threatening condition arising when the body starts to attack its own tissues and organs in response to infection. Now, the main point I want to take out from there is the fact that no one has ever yet got sepsis without first having an infection. And that's an important concept to bear in mind as we go ahead to discuss the suspicion of sepsis concept, because it focuses more on the infection, if you like, more than it focuses on sepsis. And I'll explain why that's the case in the course of the next half hour or so. So we know for a fact, of course, that not everyone who gets an infection will then develop sepsis. In fact, only a very minuscule percentage of people or patients who get infections will eventually get sepsis. And also we know that, but also as I say, nobody has ever yet got sepsis without first having an infection. So it then raises a question about how much focus we put on the infection in the first place. Now, here is the crux of the problem. The crux of the problem is that in trying to measure sepsis, there are three factors that are in dynamic interplay, which make it really difficult to put our finger on exactly what we're measuring. The first is, as you would know, there is, over the years, there's been a fluctuation in the definition of sepsis itself. And if there's been a fluctuation in the definition, if we can't actually agree or put our finger on what exactly it is we're defining, then it makes it difficult to measure it. Secondly, at least in England, and as I say, in other parts of the world, there's been such a lack of consistency in coding practices, not just between clinicians and coders, but also amongst clinicians and amongst coders. And I'll develop a bit more on that point in the course of the course of the webinar. The other thing to note is that there is no definite diagnostic test for sepsis. And so you put all these three together, and what you get is that there's no reliable way of measuring sepsis outcomes. And because of that, there's a further complication. The further complication is that we then do not have any means of demonstrating improvement. So for all you know, we might be doing quality improvement and we might be doing all kinds of initiatives, but it's difficult for us in that sort of context to determine whether or not we're making the right impact and whether we're shifting the needle in the right direction. And that's what motivated us to design the Suspicion of Sepsis Insights Dashboard. Now, one other thing to note, at least as far as the system goes here in England, is to just take you through the process of sepsis data collation, if you like. So as you know, the patient comes into hospital on admission. The patient is seen by a clinician, and the clinician makes a diagnosis. That diagnosis, of course, is entered into the patient's medical records, into their notes, whether that's manually or electronically. At the end of the process, when the patient is discharged, many times, thankfully, the patient is discharged back into the community or back or to another healthcare facility, but at least they're discharged. Unfortunately, some of the times the patient is not quite discharged because it results in a mortality. And so, but regardless of the situation on discharge, That information is then entered into a discharge summary that's written by a clinician, often a doctor. And that information is then sent to the coding department. The coding department will then decipher the information and extract the so-called ICD-10 codes from that discharge summary. And the ICD-10 codes, as you know, are the International Classification of Diseases version 10 codes. And those codes are for diagnosis. And so the coders will then extract those codes, and via a multi-stage process, they then send it to our NHS digital system. And that is then centrally collated into the so-called hospital episode statistics, which is the place where we as Imperial College Health Partners then get the data from. So we mine it directly from them. And in that sense, it's as accurate as it would get. And that leads me on to another point that's been made in the interaction with us prior to the webinar, which is around how did we secure engagement? How did we get to a point where we actually got all the organizations to send the data? It's partly because there is a responsibility on the part of each of the organizations to send the data to NHS Digital via the pathway I just described. And also it's partly because there is some incentive involved. It's called a sequin in England and in the United Kingdom. And basically it's a process by which organizations are paid a certain incentive for innovation and for quality. And it's called the sequence, which is the Commissioning for Quality and Innovation in Healthcare. And so this data process is partly linked to sequence. And so in some sense, that's one of the motivations for organizations to send their data to NHS Digital, which is where we then mine the data directly. Now, the other problem, or the narrowing this down to the suspicion of sepsis concept, the actual problem is this. There are currently 2 designated codes for sepsis, and those codes are themed A40 and A41 ICD-10 codes. However, there are about 250 bacteria infection codes. Now, in total, there are about 68,000 ICD-10 codes, diagnostic codes in total. What we've done, or what a colleague of ours, a guy by the name Martin and Kim and his team, have designed the so-called suspicion of sepsis cohort of patients, or coding system. And this focuses on 250 bacterial infection codes, which have been validated and have been published in the BMJ about 2 years ago. And these codes focus on the cohort of bacterial infection as opposed to sepsis in isolation. The reason why we've done that, and the reason why the team did that really was because, as I will show shortly in the next slide, if you focus exclusively on tracking ICD-10s, A40 and A41 that are dedicated to sepsis exclusively over a period of time, what you will find is fluctuation. And I'll explain that fluctuation shortly. So here is what the graph would look like if you were to plot the ICD-10 codes for sepsis and for bacterial infection or suspicion of sepsis. So first, notice that this green line describes what will happen if you plotted between January 2016 and November 2018. It basically shows that there is such a huge spike and such a huge fluctuation in numbers. Just so you can make sense of the graph itself, the y-axis, there are 2 y-axes if you like. The y-axis for the green line is on the left side of the screen, and the y-axis for the 2 red lines are on the right side of the screen. Now, the other thing to note from this graph really is that these broken lines, the broken red lines, are a plotting of the total number of emergency admissions over a 2-year period. So that represents the total number of admissions in a 2-year period in England. And finally, the unbroken or solid red line at the bottom is really the total number of patients who were admitted in the suspicion of sepsis category. And notice one thing. Notice that for both of the total number of patients admitted in emergency and the total number of patients admitted for suspicion of sepsis, notice that the curves are fairly even. They're fairly consistent over time. And studies have shown, and it's been published over time, that the total number of patients in the bacterial infection category, if you like, is fairly constant over time. So it would prove to be a more reliable and a more credible and a more stable measure for measuring outcomes and frequency and scale, rather than actually trying to measure sepsis, which is prone to fluctuation, as I say. I guess the other thing to notice that the two curves, both for suspicion of sepsis in the bottom curve and for the unbroken line, which is the total number of admissions and emergency admission, notice that both curves nearly mirror themselves, which again tells us that the suspicion of sepsis metric, if you like, is a good and reliable measure for tracking outcomes, for tracking frequency, and for tracking scale. So I'll go on to the next slide, which now I wouldn't spend too much time on this, but the one thing I want to point out here is we've basically just reproduced the sepsis A40 and A41 data in this graph, and notice that we could trace the spike to very specific events, national events in our healthcare economy, if you like. So if you were to go by this graph, it would suggest, and erroneously I might add, it would suggest that between October 2015 and August 2018, that there was a doubling of the number of people diagnosed for sepsis. Now, the reality is, if that were to happen, it would be an epidemic. And we know from speaking to clinicians and just from reviewing records that that didn't happen. What did happen, in fact, was there were some national events which significantly increased awareness of sepsis, and which meant that people coded, or clinicians began to code sepsis a lot more significantly than they did previously. So, for example, we know that the UK Sepsis Trust introduced a toolkit in the winter of 2015. NICE, National Institute of Care Excellence, introduced their guidelines in the summer of 2016, and so on and so forth. And we could basically trace all that spike. Every time there was a spike, you could trace that to a national event, and that's been explained in our data. Now, so the problem we set out to solve then is this problem of the previous system based on A40 and A41 basically was unreliable, unstable, inconsistent, and lacked credibility. And so it was not a good measure for scale, frequency, and outcomes in sepsis. And that's why the suspicion of sepsis category and concept was introduced. And that leads me to the second question, which is simply, what's the SOS dashboard? Now, I'd like to go through some screenshots of the dashboard. But before I do that, let me just also quickly say that in a nutshell, to, if you like, articulate in one sentence what we were trying to achieve, the suspicion of sepsis insight dashboard was actually designed to help practitioners to deliver better care, to reduce harm by achieving better sepsis outcomes. And we aimed to do that by providing fast, accurate, and targeted data. So in a nutshell, we wanted to improve care, we wanted to reduce harm, and we wanted to achieve better sepsis outcomes by providing data which is fast, which is accurate, and which is targeted at a local, regional, and national level. Now, the dashboard is live at www.sos-insights.co.uk. The data is retrospective data, and I think that's important to note. So it's not real-time data, it's historical data. And so in some sense, it helps us to relate to the purpose of the dashboard. It's free at the point of access, so it's widely available on the internet, and it's available both to members of the public and also to patients. And the data is completely anonymized, so there are no data identification issues. There are also no data interoperability issues for individual organizations, because what we know is that the data is there available for them, and they can basically interrogate it and use it for the development of their own reports. And as I said, there are no patient consent issues because the data is completely anonymized. Now, when you go to the opening page, or to the home page, I should say, this is what you see, and it gives you some basic information about the suspicion of sepsis concept itself, and helps you to perhaps get some context in how to interpret the data. You're then able to click on the start icon, which then takes you into the dashboard itself. Right on the dashboard, as you get into the dashboard further, you then see the icons at the bottom of the page, which allow you to navigate. And there are three key icons there, which are possibly the most important. There's the admissions data, which I would look at shortly. There's the bed days, and there's the discharge data. The other icons tell you about the different resources we've consulted in developing the dashboard, and different other sources of information. And there's also the reference. I think the reference is very important, because the reference actually talks you through in detail the different coding categories we've used, and which codes come in under each of those different categories. So basically, it breaks down the coding nomenclature, if you like, and gives you insight into how we've arrived at what we've arrived at. So one of the key points on the home page and the starting page really is the warning about interpreting the data carefully, not making judgment calls on the data, but using it to drive improvement rather than to make performance management judgments. That's simply because comparing one trust with another trust could be potentially a misleading thing to do, because those two trusts might serve different demographics. They might serve different demographics is a big part of understanding the data. And also, there might be different events happening geographically in those locations which affect the data, which then means that really caution needs to be taken in interpreting the data, especially in the context of comparison. Now, you then go on to the admissions page. And what the admission page does is it's designed to do three things. First, it's designed to help you to understand the demand at a local, regional, and national level. So what's the demand on this system? It gives us data about the number of people being admitted in emergency over a period of time. And the second thing it also helps you to do is, if you were to, you could toggle between the SOS category, for example, and coded sepsis. So if for any reason you decided you wanted to really not look at suspicion of sepsis, but you wanted to look at coded sepsis, you could easily do that by toggling between those two categories. The other thing you could do is you could pick out a particular trust. So you could go into this drop-down menu, and it gives you the entire list of all the organizations in England. And so you could pick out the one that you wanted to interrogate. Secondly, just on the right-hand corner, top right-hand corner, you can also decide which infection category you want to focus on, and that will then reflect in the graph. And if you scroll over the graph, it basically shows you what the numbers are for each of those different time segments. And then if you were to scroll down, a bit more, there's another graph just at the bottom of the page, and that basically also tells you about emergency SOS admissions over the period of time that's represented in that graph. So basically, what this page helps you to do is three things. First, it helps you to see the total demand on the system, which is very, very helpful for planning. But also it helps you to see the seasonal variations in that demand. And as I would describe later, this has been very helpful, and one of our regions in England has put this to very good use in terms of understanding their seasonal demands. So that's the second thing it helps you to do. But the third thing it also helps you to do is to understand your demand and your outcomes over time, and also to perhaps layer that with an understanding of the impact of any interventions that you have done over a period of time. And that's one of the things that is very important about the admissions page. The next page is about bed days. And the bed days helps you to understand what happens to the patient once they come into hospital. And so it helps you to understand, for example, what's the ratio of bed days in terms of standard hospital beds and ICU beds, for example. And again, what that helps us to do is a number of things. First is it helps us to understand bed utilization. It helps us to understand how perhaps we could match our demand from the previous tab to actual bed usage. And so by looking at those data or those two data sets side by side, we can make some very important strategic judgments about planning for the future. And also understanding the bed usage in terms of seasonal patterns is another thing that this page helps us to do. And on top of that, it also gives some very specific information about not just bed usage, but also, as I said, as it breaks down between standard bed days and ICU bed days. And also, you could break that down by suspicion of sepsis, or you can break it down by coded sepsis. It also gives some percentage of, so it also helps you to know the total percentage of suspicion of sepsis admissions as compared to the total number of admissions. And you get that in a percentage. It also shows you the emergency SOS admissions average length of stay. And further down on the page, it helps you to see the emergency SOS admissions ICU bed days. So it gives you some really good data, both at a local, regional, and national level. And again, as I said in the previous tab, if you were to click on this icon, or on this drop-down menu, I should say, it basically lets you pick your trust. If you click on this drop-down menu, it allows you to pick an infection category, and that would have an impact on the data that's being displayed. What I haven't said is that for any of the reports or any of the graphs you choose to display, you can also export it. There's an export function that allows you to export that easily. And also, there's an opportunity for us for you to provide feedback on what it is that you've seen, or if you wanted to drill the data further and you wanted some input from us, that's something that you can do. And that information immediately comes to me via email, and I get the constant flow of information which I'm able to respond to. So that then takes us to the final data page, if you like, which is the discharge page. A number of things about the discharge tab and the discharge page. First thing is it helps us to ultimately decide what impact our interventions are making. So if we introduced a particular quality improvement intervention at this at a certain stage in the pathway, ultimately this data helps us to see if it's working or not over time. The other thing that the data also helps us to see is basically it helps us to see what the data is in terms of mortality. It helps us to see the data in terms of specific disease conditions. So, for example, does the mortality vary by disease conditions, for example? So are we likely to have more mortality with respiratory conditions than we have with musculoskeletal conditions, for example, or neurological conditions? So it helps us to understand mortality and readmission rates and other parameters at a very, very nuanced level. So you can begin to paint a picture as to exactly what's happening in your own organization and how you might respond to that. What this also does, a very important feature of this is it helps you to toggle between survival and mortality. So, for example, members of the public might prefer to use the word survival. They might prefer the fact that 95% of patients survive rather than 5% of patients die, sort of thing. So again, that's just a presentational issue which allows us to, if you like, toggle between mortality on one hand and survival on the other. So this page is about really helping us to drill down and understand our outcomes, both in terms of mortality on one hand, but also in terms of percentage survival and readmission rate, 30-day readmission rate. And also understanding that by drilling down by disease categories. Now, so in terms of the actual data, that's all the data tabs already covered. There's an improvement page, as I said, gives us some resources or points you to some resources and some other organizations that might be helpful in terms of the work that we've done and providing other resources. And that takes me to the, actually before, let me just go back one step. What you're also able to do here after going through the resource page is to look at exporting the data. There's a function for doing that. There's also now a function for actually talking through the dashboard and providing some guidance. So we've actually then provided some guidance so you could see what each of the pages do. And you can basically get a bit of a quick run through how to use the dashboard. And as I mentioned earlier, there's a feedback function. Now, that takes me on to the third question. How is the dashboard being used at the moment? So there are about 6 different uses that we've identified over the last 7 or 8 months. The first is that our colleagues, clinicians, are looking to use this primarily to drive quality improvement, which is one of the reasons why we designed it. And in fact, really is the primary reason. And it's about getting reliable baseline data. If you don't have reliable baseline data, it's difficult to do quality improvement because you don't know in what direction your impact is. The second thing, of course, is that because of the information that's available, it also helps our colleagues on the front line to be able to diagnose where exactly are the issues and where they need to be prioritizing their resources. So, for example, looking at the issue of disease conditions, it may well be that for the SOS categories, that a certain organization does not have any pressing problems for respiratory conditions, but they might have, for some reason, they might have problems with neurological conditions. So it helps them to diagnose which pathways to really focus on, and so make an informed decision on what interventions to focus on in quality improvement. The other one, of course, is to track outcomes over time: mortality, survival, bed days, 30-day readmission, ICU admissions versus standard occupancy sort of thing. The third is that it helps us to plan in terms of resources. So first, in terms of forward planning, where should we be investing more resources for the future? How do we balance our demand with our capacity? what are the seasonal variations in demand, which then means that perhaps the potential for seasonal variation in capacity and capacity planning. And of course, what particular disease categories or pathways might be more important than others in terms of the usage of resources. How do we allocate resources in what issue? That sort of question, or those sorts of questions are also help ways in which clinicians have been using this. Another one is benchmarking. Although we're careful to encourage our colleagues not to benchmark in terms of comparison, in terms of performance management, but to benchmark for the purpose of quality improvement. So it's all well and good for me as an organization to look at a comparable organization in terms of size and demographics and to see where they might be doing better than my organization, with the view of perhaps speaking to them, to learn from them, and to share experiences and lessons. However, as I say, we've been very careful to discourage using that as a performance management tool. Then there's the aspect of demonstrating impact. And I'll feature one particular example, which is from our West of England Patient Safety Collaborative. So I work for the Northwest London Patient Safety Collaborative, and my colleagues in West of England, some time ago, over a period of about 3 or 4 years, they introduced the National Early Warning Score across every clinical setting. And they became the first region to introduce the National Early Warning Score across all care settings in England. However, despite the fact that they knew that that was something good to do clinically, because the evidence has shown that the use of the National Early Warning Score is a good predictor of patient outcomes, and it's in fact a good predictor of better care. And also, it's better for communication between clinicians across settings. However, despite the fact that they knew that, they still could not put their finger on one single measure to demonstrate their outcomes or their impact. However, when they came across the Suspicion of Sepsis Insights Dashboard, and they looked at their data in comparison to other regions of England, it was obvious that for suspicion of sepsis, their mortality was significantly better, statistically better, excuse me, than any other region in England. Excuse me. And so that was a way of demonstrating the impact of an initiative. Excuse me. That was a way of demonstrating an impact of an initiative that had been done over a period of time. And so that was a very a test case, if you like, in demonstrating the impact of the dashboard, or potentially the use that you could put it into. The final thing that our colleagues have been doing is to understand population trends. So, for example, our colleagues in Wessex in England and the Wessex region, what they have done is to drill down on the so-called winter pressure. Now, it's already a known phenomenon in England that in the winter months, there's a so-called winter pressure, which means a sudden surge of demand in the emergency department or in accident and emergency department. And when you say that to an average person or even an average clinician, the picture they get is that over the winter months, from about October all the way till February, that there's a sudden insurge of patients and a significant increase in demand over those months. But when Wessex looked at their data from the Suspicion of Sepsis Dashboard, they discovered something that they were not expecting. They discovered that, in fact, winter pressure for them meant two things. First, it meant that there was a sudden increase in demand only in the month of January. And secondly, they discovered that in fact, the increase in demand was only exclusively associated with respiratory conditions. And with that kind of data, with that kind of intelligence, you can be so much more nuanced and so much more effective in planning ahead for so-called winter pressure, and in targeting your resources, and in making the capacity available for dealing with those situations. Now, I'm well aware that we're probably quite quite far on with time, and I need to start to round up in some shape or form. So I'll just, Mary, how are we doing with time? How much time have we got left for this part?
I think a few more minutes would be fine, Kenny.
Right. Okay. So I'll just quickly deal with a few more slides, and I'll hand right back over to Mary. So in terms of impact, in the last 7 months since we launched the dashboard and it became public, the last 8 months now, actually, we have had engagement from 10 professional organizations. Some of them are medical organizations, others are nursing organizations. We've had input from patient representation, and we know for a fact, based on data that we track and collate, download data and personal email exchanges and face-to-face contact with colleagues across the nation, that there are 60 trusts, at least 60 trusts at the last count, who have now adopted the dashboard. And now one of the things that has fascinated us and has really given us a lot of delight really is that a lot of this has happened by diffusion. At the moment, we're planning a formal spread program, but that actually hasn't taken off. So technically, we're still in implementation stage, but diffusion is already happening, and it's happening at a rate that's quicker than we could ever have predicted. The other thing, of course, we also know is that we know for a fact that there are at least 110 colleagues and clinicians across the nation who are personally interacting with the dashboard and using it for different professional purposes. And we have documented evidence of that. I'm sure that for every professional that we have of documented evidence of, I'm sure there are others that we haven't yet been able to track, but who are equally using the dashboard. And we know that the Minister of Secretary of State for Health picked up on the dashboard. We don't quite know how, but he announced it rather surprisingly, really, in his maiden patient safety speech, and potentially that has also helped the spread of the tool. And a number of one other minister has also featured a tweet on the dashboard and also done a video clip to support it. I say all that to say that potentially those are perhaps ideas for spread. If this was something that you decided to adopt in your healthcare system or in your own nation, in terms of expediting spread. Now, so lessons learned. What have we learned in this period? What exactly are the lessons that we've learned? First is to adopt a cross-system approach. In our approach, we've included primary care, secondary care, tertiary care settings. And the second is to engage clinicians from the outset. That we learned that the hard way because we started out first. Even though we got input from clinicians, we didn't necessarily involve them as the face of the concept. And that didn't quite go well because potentially you could run into confrontation by presenting data to clinicians, data that they may not necessarily be happy about. But we found out that it's easier when the data is being presented by a fellow clinician, and it's less confrontational and less threatening that way, just by changing who presents it. The other thing we found out is it's been very important to adopt a multidisciplinary approach, including patients, coders, analysts, doctors, and nurses. And the need to collaborate across systems and to collaborate across agencies has been very key. And finally, involving professional associations, and I list a number of professional associations that we've interacted with, either in terms of asking them for sense checking the data, or in terms of presenting at workshops and so on and so forth. Just one final thing also has been the role of champions. So, for example, the work on the definition of sepsis, the current definition of sepsis was done by Mervyn Singer and colleagues internationally. And Mervyn Singer happens to be one of the people on our advisory board. And we found it very helpful to get such reputable names and champions involved in advising and critiquing the work that we did. So what are the opportunities for collaboration? I think is what I need to quickly cover in the next minute or so. Now, we know for a fact that the work we've done is applicable to other geographies in the world, not the least because we've had inquiries from other parts of the world. So, for example, we've had inquiries from the United Arab Emirates. We've also had inquiries from New Zealand, and we've had inquiries from some other geographies, if you like. And so we know that this work is applicable in other places. And in terms of what we're offering is to work alongside other geographies who might be looking to do this. And I read with delight some of the information previously provided to us. And one of the people I believe on the webinar today mentioned about the potential of working together to do a similar piece of work across a national, across their own geography nationally, and that's something that we would be happy to do. Potentially, we could collaborate perhaps on comparing notes, sharing lessons, but also potentially doing joint publications and so on and so forth. And so what would be really good is to be able to replicate in another nation what we've done in England, and then to be able to use that as cross-validation, if you like, of our data. I'm sorry I had to rush through so much information in a short period of time, but I think at this point, I'd like to hand back over to Mary.
Kenny, thank you for sharing your work with us and for leaving our network with some interesting opportunities to collaborate with the Imperial College Health Partners. At this point, we'll open the floor to questions. Just as a reminder, you can use the chat function by typing in your questions into the box that you'll see within the control panel, or to pose live questions, please feel free to use the raise hand function. We welcome questions, comments, and your reflections along with your name and affiliation if possible. Now, I see that we have a few questions already lined up, so I'll tie these questions together for you, Kenny, and perhaps you can take them on as best you can in light of time. Our first question here is, what does the data mainly get used for? Technical purposes, or has the data also been used for strategic decision making? Our second question comes from Meera Joshi, one of our researchers at the Institute of Global Health Innovation at Imperial College, and she is wondering about the academic analysis of the data. Is anyone working on that yet? And the third question we have is regarding impact. So what has been the impact so far of using this dashboard?
Right. So in terms of the current usage, it's mainly strategic. It's mainly used for planning quality improvement projects. And so because the data is historical, in future, we hope to get it to the point where it's much predictive. At the moment, it's retrospective. So I think that's a short answer to that question. In terms of current research work that might be happening on the data, we know that our colleague who I referred to earlier, who actually wrote the codes in the first place, is doing a piece of work to validate the Suspicion of Sepsis codes across 5 centers in England. And the idea is to look at the coding or to look at the data on Suspicion of Sepsis from the dashboard and validate that by looking at case records and looking at case notes. So, and that's a piece of work I believe you'll be publishing at some point in the future. But that piece of work is still ongoing in terms of the research. I believe those address the couple of questions that were raised.
Perfect. So we do have just a little bit more time, and we have one more question here about how long does it take to get from coding? How long does the coding take through NHS Digital onto the dashboard?
Right. So at the moment, there is a minimum time lag of 2 months because of the time it takes to validate the data, to adjudicate over it, and then process it. However, we're looking at shortening that process. And actually, there are 2 elements to this. There's the one element of how long the data gets how long it takes to get from the trust or the organization to NHS Digital, and for that data to then be sent back to us. And that's the 2-month period. The other thing that we also will be looking at is how quickly we can then take the data from NHS Digital and update it on the website. That's something we're also looking to shorten. So when we launched the dashboard about 8 months ago, it took us about 4.5 months to do the first data refresh. But the second data refresh only took about 3 months, and the next one is going to take us 2 months. So we're in the spirit of QI, we're increasingly looking to shorten that period. And ultimately, we're looking to get this as close to real time as possible.
Thank you, Kenny. Now, to wrap up, since I am conscious of time, I'd like to invite you to leave our audience with a few key messages.
Right. So there are 3 final key messages, really. One is that we need credible, accurate data to make quality improvement. The second is that data needs to be quickly and easily accessible to be useful on the front line and to inform decisions. And the final really is that data needs to be bespoke and lend itself to detailed analysis. Otherwise, it becomes really difficult to really make progress in quality improvement.
Thank you for that. So for any other questions that our audience might have or comments that we might not have time to address, please do feel free to send us those questions via email at lhsn@imperial.ac.uk. And also, if you'd like to explore some of the collaboration opportunities, I think Kenny has left his email on the slide. There you have it. So do please feel free to get in touch. As a reminder, the recording of this webinar will be available on our website at www.leadinghealthsystemsnetwork.org, and new webinar announcements will be posted on LHSN's social media accounts. So feel free to follow us on LinkedIn, Twitter, and YouTube for that information, or sign up for the LHSN newsletter on our website. So with that, we conclude our session. And on behalf of LHSN, thank you for joining us. And Kenny, thank you so much for your presentation. Hope you'll stay tuned for our next event. Bye-bye.
Thank you.